It's clear.
Can you see him?
Yeah.
All right, great. Just give me a second to. All right. So, good evening, everyone in Africa, Middle East, and in Europe. Good afternoon, everyone in the United States of America, and good evening, everyone in some parts of Asia. On behalf of Orthopedic Surgery Department at Al-Azhar University, and being one of the colleagues of this lovely department, I would like to express my great proudness to invite and receive and host two of the eminent guest speakers who, in spite of the pandemic of coronavirus, which affected everybody in the world, they traveled across the Atlantic from the lovely city of New York to be here with us in Cairo for a short visit for 2 hours. And I hope they enjoy their stay with us, they enjoy our weather in spite of the summer, and I hope they could enjoy the speech. And I'm asking them that this is not the first time to be here. And of course, they will come virtually and actually back again. Today is a special day because our guest speaker is coming from a special hospital for special surgery. And today our topic about osteotomies around the knee, how I do it, and under complete supervision and guidance and sponsorship from our leaders, Professor Mahmoud Siddiq, who is the Vice President of the University and is orthopedic surgeon as well. Professor Hussein Abul Ghait, who is among us today, thank you for your Professor, and is the Dean of the Faculty. And Professor Ismail Yassin, the head of the Orthopedic Surgery Department. In collaboration with the Hospital for Special Surgery, which is one of the biggest hospitals in the eastern part of the United States of America, we are all welcoming Dr. Robert Rosbach, Chief of the Limb Lengthening and Complex Reconstruction Service, and Dr. Austin Fragman, my friend, welcome to you, Associate Professor of Orthopedic Surgery as well. Thanks for Elixir Pharma who sponsored this meeting, and it is live on the Facebook now. And many thanks, especially for Dr. Mustafa Aweda and Dr. Anna, who organized this in time. A few words about my university. Al-Azhar University is associated with Al-Azhar Mosque in Islamic Cairo, and it is Egypt's oldest degree-granting university. In addition to higher education, Al-Azhar oversees a national network of schools with approximately 2 million of students. To be noticed, the students came from all over the world, especially from Africa and Asia. And this is my lovely faculty of medicine from which I graduated. And this is our university, which is considered to be one of the biggest territory among the Middle East. Every year, faculty of medicine is graduating about 400 to 500 doctors annually. And this is my lovely department with all professors, associate professors, and lecturers, in addition to 25 more assistant lecturers and residents, not only for limb reconstruction and service, but everything, spine, microsurgery, arthroplasty, arthroscopy, and everything. So the orthopedic surgery department is one of these big parts. And since the start of the pandemic, orthopedic surgery department at Al-Azhar University took the leadership to invite and make workshops for under and postgraduates inside and outside the country. So not only nationally, but internationally, we got the chance to invite Professor Bailey a couple of days ago. And today, of course, Dr. Rob and Dr. Osterman among us. Thank you. Dr. Robert Rosbach, since 2012, he is the professor of clinical orthopedic surgery at Weill Cornell Medical College in New York. From 2015, he is the director of Limb Salvage and Amputation Reconstruction Center. And from 2005, he is the chief of Limb Lengthening and Complex Reconstruction Service, and also the Hospital for Special Surgery Orthopedic Leadership Council. I had the chance to meet him in different international meetings without remembering all LRH meeting in Charleston, LRH Congress in Liverpool in the UK was a fantastic meeting, and also another one in the lovely Lisbon in Portugal. So every time I see him, I took that chance to collaborate socially and scientifically as well. And honestly, to speak in front of him as a speaker in front of a moderator and panelist, it is like a dream. And also, I enjoying his comments and his positive comments every time he listened to me. Thank you, Dr. Rob. And not only that, actually, I had the chance to mention one of our research, which is my favorite, under my name, Dr. Sean Standard, Dr. Robert Rochbuch, and Dr. John Hargenberg. He's my leader and mentor for a couple of years in Baltimore. Austin Fragman, my friend, is from 2013 Associate Professor of Clinical Orthopedic Surgery at Weill Cornell Medical College, and also Associate Attending of Clinical Orthopedic Surgery at HSS. And he is the Fellowship Director of Limb Lengthening and Reconstruction Service, and he is the past president of LLRH Academy of North America. And without too much photos, I had this photo with him. I don't remember exactly where that, maybe in Charleston as well. So orthopedic department and Al-Azhar University, actually we're all welcoming both of you coming among us. And this is our agenda today. And let us start by the first eminent speaker, Dr. Rob. Please, the mic with you. Thanks. Can you share the screen?
Yes. Can you see my screen?
Yes, we hear.
Okay. Okay, well, first I would like to thank you all for this very gracious invitation. It's really an honor and a privilege for both myself and for Austin to present to you and collaborate with you. And, you know, this is particularly meaningful for me as I was supposed to be in Cairo last week. And I was looking forward to my first trip to Egypt, and unfortunately that didn't happen, but I know we'll be able to do it at some time in the future. So I know that many of the people on this webinar are actually people that I would have met in person, and so it's a bit bittersweet to be doing it virtually, but this is the next best thing. Okay. Thank you especially to you, Ahmed, for putting this together. It's very nice, and I've enjoyed our friendship and our collaboration over the last several years.
Thank you so much.
So, you know, osteotomies about the knee are a very nice topic that applies not just to limb reconstruction surgeons, but to orthopedic surgeons in general. So my talk is going to be with an emphasis on distal femoral osteotomy, but it'll have a little bit of everything, and in Austin's talk is going to kind of be the reverse, but I think you're going to see lots of different examples of simple and complex osteotomies about the knee. I do show some patients' faces, which I always enjoy doing, and just please know that those patients have given consent for this. So whenever we talk about a realignment osteotomy, it's important to understand we have to know certain definitions like mechanical axis, what our goals are, and various joint orientation angles. And so this is a little bit beyond the scope of this lecture to go into all the details of this, but it is important that these things become part of the nomenclature. So people with valgus deformities, that is where the mechanical axis deviation is lateral to the midline, are at risk for developing progressive arthritis on the lateral aspect of the knee, as you can see in this patient. And the reason for that is that as you go from a neutral mechanical axis, you can see that the force increases quite dramatically And in this example, showing you 10 degrees of valgus deformity. The red line is the pressure on the outside part of the knee, and the blue line is the pressure on the inside part of the knee. So with valgus of 10 degrees, you get a very large increase in force on the lateral aspect of the knee. And essentially, there's no force, no compression on the medial side of the knee. And you get, in fact, distraction, or you get tension. And so the important take-home message here is that deformity overloads the respective compartment of the knee. So let's use Nicole as an example. She's a 30-year-old female who played basketball in college. She now has pain in her left knee, but she's always been conscious about the appearance of her knees. She has a grandmother who's needed knee replacements, and she's concerned about this. When you look at the X-rays of the knee at first, you do see joint spaces that seem to be well maintained. Patella are stable, but a flexed knee view actually shows you that there's quite a bit of narrowing on the lateral compartment of the left knee. So the most important thing that you can do for this patient is realign her and change the biomechanics of the knee. It starts with looking at joint orientation angles to understand the source of the deformity, which is the femur in this case. And then you can do osteotomy planning by performing a virtual osteotomy with this type of a software. And you can see our goal is to realign the mechanical axis to the center with 9-degree corrections on both sides. In the operating room, we execute this by creating a distal femoral osteotomy, which does not violate the medial cortex. We have various trials that we can place with different angles and wedge heights based on our preoperative templating, and we can confirm that we are realigning the knee by using this alignment rod in the operating room. And then we replace the trial with an allograft wedge and with a locked titanium plate. These heal up very, very nicely. This is an X-ray at about 3 months after both sides have been done in a staged fashion. You can see that the patient is well realigned, and both on X-ray and clinically. The operative technique involves a 6-inch lateral skin incision over the lateral aspect of the knee. The osteotomy is done. Again, an important technical point is not violating the medial cortex. You'll notice that I aim my osteotomy into this metaphyseal bone rather than this diaphyseal bone, because this is more flexible and will not crack. And then we distract it gradually by using laminar spreaders in a very controlled fashion. And then it is ultimately stabilized with a plate. The alignment is checked in the operating room. I like to use a solid alignment rod, and this has been very, very reproducible. And then you can change the amount of the wedge height as is needed. We have looked up our results, early results of this technique with Osama El-Attar. Perhaps he's part of this meeting. If he's out there, hello, Osama. Hi, Sam. Basically, it was a nice review to really show that the accuracy of these corrections was quite significant. We also learned along the way that patella instability is well treated with this technique because of a change in the Q angle and a change in the way the mechanics of the patella. So if you combine a lateral release with a distal femoral osteotomy, you actually are treating patella instability in most cases without the need for any other procedure. In that study, the mean follow-up was 26 months. All patients achieved union at around 3.2 months, and the accuracy of correction was 95%. No patients had any loss of knee range of motion. And we showed significant improvements in mechanical axis deviation, lateral distal femoral angle, and patella congruence angle. Functional scores, including SF36, lower limb module scores, also had substantial improvement. So here's an example of a woman who has bilateral genovalgum. She's 25 years old, lateral mechanical axis deviation, and she's got 11 and 8 degrees of deformity on the left and right sides, respectively. Now, what's different about her than the last case is that she has patella instability. Every time she bends her knee, her patella goes in and out of the trochlea. And it's very bothersome to her. It's painful. It's annoying. It creates anxiety. You get a sense of it on these merchant views. You get a sense of it on these AP views. So dislocating patella. Now, the only thing that I did differently on this case, I did the same operation, which is the distal femoral osteotomy, the realignment. But I do want to point out the sort of the concept of how the distal femoral osteotomy, really with the apex of the correction in this location, what it actually does is it creates a translation of the tibial tubercle. It medializes the tibial tubercle. And that is in fact what is happening when you're improving the Q angle. And so that, combined with releasing the tight structures along the lateral side of the patella and the patella tendon, really a good lateral release all the way from the top of the patella all the way down to the tibial tubercle, will, in my experience, in most cases, take care of patella problems. You always have to be prepared to add additional procedures as is needed. But in my experience, this takes care of the vast majority of the patella instability that I have seen. So in the end, you can see she's realigned. The osteotomies have healed. The Q angles have been corrected. The patella are now stable. And of course, from an aesthetic point of view, she is also very, very happy. The aesthetics and the improvements in body image are not to be underestimated in these patients. They're actually quite significant. I'd like to show you another case. This is GN, who's 50 years old. She has lateral compartment arthritis. She's got a large valgus deformity. I think in this age group, sometimes you get into the discussion about osteotomy versus joint replacement. And you know, these patients are sort of, I think that they're on the borderline, and it's reasonable to do a joint preservation approach, and it's reasonable in some cases to do an arthroplasty approach. It's not a one size fits all. Sometimes it depends on the patient preference. But you can see here, her right knee has a very large mechanical axis deviation, 56 millimeters lateral to the midline. And interestingly, she also is long on that side, right? So she has a leg length discrepancy, and she is long on the deformed side. So slightly different approach. Here, it's a large deformity, and you can see from the joint orientation angles 80 and 96 that the source of the deformity is actually coming from both the distal femur and the proximal tibia. And so at a certain point, when the deformity is large, and I think that once you start seeing deformities that are above 10 or 11 degrees, you should really ask yourself the question, where is the deformity coming from? And does it make sense for me to do 2 osteotomies above the knee and below the knee? You might get different answers in different cases, but you need to ask yourself that question. Here, my approach was a distal femoral osteotomy and a proximal tibial osteotomy. That's going to split the correction, and it's going to keep the knee from being oblique. Now, because she was long on that side, I actually chose to do shortening osteotomies, and I did a medial closing wedge osteotomy on the femur, and I did a medial closing wedge osteotomy on the tibia. And this is a technique I like to use. Once I cut out the wedge of the appropriate length, I use an articulating tensioning device after I fix the plate on one side of the osteotomy, and I gradually will compress the excised triangle. And so this is what it looks like. I can check my mechanical axis. If at any point I don't like it, I can always decrease the amount of compression, or I can take more. So I have that option while I'm doing this. So this is what it looks like in the end. You can see we have corrected her mechanical axis deviation exactly as I wanted, with a slight degree of overcorrection, considering that she has lateral compartment arthritis, and you can see the aesthetic improvement in that situation. Now, this patient is 20 years old, has valgus deformity, and let's focus on the left knee. She has patella subluxation, persistent patella subluxation, despite procedures done by other orthopedic surgeons, which included a tibial tubercle osteotomy and an MPFL reconstruction. So what's missing? You know, what have these other doctors missed where this patient continues to have pain, continues to have patella subluxation? Well, at this point, I start to think about the deformity, okay? And so the valgus and the Q angle is a big component of it. So one thing that has been omitted in the treatment is correcting the valgus, which we already touched upon. But sometimes I will also ask myself, is there a torsional deformity? In other words, is the knee internally rotated relative to the patella? Now, anybody who does knee replacements knows that putting your femoral component in internal rotation is forbidden, right? That's the worst thing you can do, right? You're guaranteed to have patella subluxation. So what has become apparent with experience is that valgus is a key risk factor, but in many cases, femoral anaversion, or a better way of thinking about it here perhaps, is internal rotation of the knee relative to the hip as being a risk factor. So we can get a CT version study to understand the extent of the rotational deformity, and then we can decide whether it's important to correct that or not. And in this case, I thought it was important to correct that. So what did I do? I have, in this situation, what I like to do, and there's different ways to do these things, but I tend to do my rotational correction in the diaphysis with a rod, and then I do my distal femoral osteotomy in the same manner that I showed you, distally combined with the lateral release, right? So I'm externally rotating the knee, and then I'm also doing this. So essentially what we're doing is we're doing a double level osteotomy, right? And when you use external fixators, the idea, the lingo of a double level osteotomy is very, very familiar to all of us. So this is essentially a double level osteotomy, but using internal fixation. And in the end, you can see I've realigned her mechanical axis optimally. I've changed her rotation, and I didn't do anything with her tibial tubercle. I didn't do any MPFL. You know, I didn't do any of those issues. And you can see how the patella is completely stable. It was really quite a dramatic difference from the preoperative situation. Okay, so the next thing that I'd like to show you is sort of the idea of treating valgus with a distal femoral osteotomy. But here I need to make up length as well. Okay, there's a leg length discrepancy of 20 millimeters, and I'm trying to make up length at the same time. So I do my planning, and I plan my osteotomy in the distal femur, and I'm planning to use an internal lengthening nail. And so what we have learned is that when doing metaphyseal osteotomies to correct deformity, in addition to lengthening, blocking screws are an important part of the technique. Okay, blocking screws are a very important part of the technique, because the direction that you place your nail in the metaphyseal segment really determines the ability to correct. Okay, So if you look in this case, I placed my blocking screws so that it forces my nail to be in a particular direction. And that is the key to the ability to correct. We also use a fixator. It's a fixator assisted technique. And the idea is do the osteotomy, hold it in place with the fixator, and then ream. So what you can see here is the osteotomy has been performed, it's been corrected, it's held in place with a simple fixator, and then it's reamed, and then the nail is inserted. And by doing that, we've corrected the deformity, and now we can use the internal lengthening nail to affect a lengthening. It didn't need a big lengthening, but you need a 2 centimeter lengthening. And this would not have been possible if we had just used a distal femoral osteotomy plate. The plate would have corrected the valgus, but it would not have corrected the leg length discrepancy. And that's really part of what the patient came in with. The problem list included valgus, but it also included leg length discrepancy. Now, just a technical point, when you're doing a retrograde nail, be aware that there is a bow in the femur in the proximal mid-third. And so it's, unless you're prepared to do a second osteotomy, which you really should not need to do, you are generally using a nail that is not the full length of the femur. So distal femoral osteotomy for realignment. Some take-home points. Realignment decreases the load on the damaged compartment. Distal femoral osteotomy improves pain, body image, and delays or avoids total knee replacement. The best results are done when there is earlier, right? When there's only mild to moderate degeneration, as opposed to advanced degeneration. But I will tell you that distal femoral osteotomy improves symptoms of arthritis and pain in all stages of arthritis, even in advanced arthritis. DFO with lateral release will improve patella subluxation by changing the Q angle, and add an external rotation osteotomy when there is excessive femoral anteversion or internal rotation of the trochlea if there is patella instability. And use a lengthening nail if there is also leg length discrepancy using a fixator-assisted nailing technique combined with blocking screws. Remove hardware as a routine. It'll make future surgeries easier if needed, and always be thinking about the future knee replacement. Don't burn bridges for a knee replacement down the road. Okay, so let's talk a little bit about varus malalignment of the knee. And you've seen this graph before. And really what you're seeing here is that just as valgus increases the lateral compartment load, varus increases the medial compartment load, which is the blue line. Okay, so in a patient who has varus deformity with medial mechanical axis deviation, they're at risk for developing medial compartment arthritis, as you can see in this long X-ray and the X-rays of the knees. So the different approaches for varus deformities include simple approaches when it's a simple problem, and more complicated approaches when it's a more complicated problem, right? Don't use one tool for everything. Okay, I think we've learned that we have different options, and we should use different tools for the different techniques. So here you can see on the left side, the patient is a 40-year-old male. He has medial joint space narrowing, and he has a medial mechanical axis deviation. He's got an 11-degree correction, about 9 degrees to neutral, but the goal here is to do some overcorrection, right? And this is a uniplanar deformity, less than about 11, 12 degrees. And this is one that can be dealt with acutely with a plate. I will tell you also that we have learned that the combination of unloading plus microfracture and injection of stem cells is also a helpful option in some of these patients who have cartilage defects. So in this particular patient, you can see at the time of surgery, we performed an arthroscopy, and he had a contained lesion of his distal femur, and we performed microfracture, added stem cells. Combine that, of course, with a realignment. The realignment is the most critical part to unload the medial compartment. And we were able to use an opening wedge osteotomy technique with a plate and screws. And you can see we have accomplished our realignment with slight degree of overcorrection. A year later, when I took out the plate and screws and we did a routine arthroscopy, we were able to demonstrate that there was quite nice filling of the cartilage defect from this procedure. Now, there are times where you need a more complicated approach. And so the indications for a hexapod frame include more complex situations. And I would say uniplanar deformity, start thinking about it when it's more than 12 degrees, or if there's complex multiplanar deformity, or if there's poor soft tissue and you don't feel comfortable, you don't think it's going to be safe to do an acute correction. Now, the hexapod frames basically are also called 6-axis deformity correction because you're correcting an angulation and a translation in the frontal plane, the sagittal plane, and in the axial plane. And so the principle is that you apply a frame to match the deformity and then you straighten it out over time. It can be used for fractures, but it works really, really nicely for complex deformity. So one of my indications for this is a patient who has a combination of varus and external rotation. You'll notice that the patella are internally rotated. And really what this is a combination of varus and external rotation. And so the hexapod frames work really nicely to gradually correct both of those components of the problem and to realign the mechanical axis and also correct the rotation. And doing this in a 25-year-old will really change her future, right? You change the mechanics of the knee and it's going to change where she's going to be in the future. I want to show you this case because it illustrates an unusual situation, okay? If you focus on the right knee, you can see the patient has knee pain. She's 25 years old, she's athletic, she's a personal trainer, and she's got genu varum. But there's something weird about this knee, right? You can see that there's a lot of obliquity in the joint line. And so even though there is a large varus deformity, and immediately one might think, well, let me just correct the tibia. In fact, when you start analyzing this, you can see that there's a lot of valgus in the femur, and there's a huge amount of varus in the tibia. And so rather than ignoring the valgus in the femur and sort of saying, well, I'm going to just use that to make my correction easier, what I actually decided to do here was to correct both sides of the knee, correct the valgus in the femur, correct the varus in the tibia. The valgus is similar to what I have shown you, right? It's a simple deformity with an opening wedge osteotomy, but the tibia is a 17-degree varus tibia. Now, 17 degrees is too much for an acute correction using a plate. And if there's ever a good indication for a fixator, for a hexapod frame, this is actually a nice one. And so that's what I did. I used a hexapod, did the osteotomy, gradually corrected, dialed in the alignment, and you can see this is what it looks like in the end. Now, it heals up very nicely. The frame came off at about 3 months. And you can see not only did we realign her mechanical axis, but we've really reoriented her entire knee. And we've gotten rid of the obliquity of her joint, which was very important and really had a dramatic improvement in her symptoms. The hexapod frame is also extremely useful when there is leg length discrepancy combined with a complex deformity. So this is a teenage boy who had an ACL reconstruction and unfortunately had a complication where he had a growth arrest of his proximal tibia in the anteromedial side, and he ended up with a varus and recurvatum deformity with leg length discrepancy, right? And so you can see this is the planning for the sagittal plane correction. And you can see this is the mechanical axis deviation in the frontal plane, and this is the planning for the frontal plane correction. And so the hexapod frame works really nicely here to match the deformity. You can see the frame has varus and recurvatum in it, and will also be used for lengthening. After the correction, the mechanical axis has been corrected nicely, and you can see you can really see he needed 6 centimeters of length. There's no good way to do this without a fixator. I mean, you know, even with all of the new techniques that we have and using internal lengthening nails, I think for a correction like this, this is really the best technique. The point is that you've got a lot of different tools, and you've got plates, you've got nails, and you have to choose what you think is going to provide the best ability to correct the deformity in your patient with that given problem. And this is the final case that I want to show you that illustrates a combination of a knock knee, right? But this patient has advanced arthritis of the knee, okay? So he shows up to the doctor, and the doctor wants to do a knee replacement. Now, it's very easy, you know, it's very easy if you're taking an x-ray of the knee and you're really only showing the knee to really miss what's going on here in the big picture. Because this patient has a malunion of his femur, he's got a varus malunion, he's got a valgus malunion of the tibia, and just putting in a knee replacement really would not be doing him any good service. So this falls into the category of patients that have extra-articular deformities with arthritis, and they really need prep work before a knee replacement, right? And so if you look at this, there's a varus procurvatum deformity of the femur. So I'm going to treat that with a nail. I think a nail is going to work well, and it's pretty straightforward. And there's a valgus recurvatum of the tibia, similar to the case I just showed you, and I'm going to treat that with a fixator. And so this is what the fixator looks like at the end of the correction. This is the static and acute correction of the nail, and you can see his mechanical axis has been dramatically improved. Now, a couple of things that are really important to understand here. This patient now can get a knee replacement. That's number one. But number two, I will tell you that these patients will tell you, they'll say to you, wow, my knee feels a lot better. And do I need to have that knee replacement now? Can I wait? And of course, the answer is sure, you can wait. So what we have learned is that deformity correction in the setting of arthritis of the knee will improve symptoms. Doesn't mean they won't need the knee replacement, but you can almost think of the operation as having two purposes. So in conclusion, I will say some thoughts on osteotomy. Sometimes when it comes to timing, you know, there's always this tension about, am I doing this too early? Is it too late? And I will tell you that it's best to realign your car before your tires are worn out. Okay, so in general, do your osteotomies early, do them on young people, and do them before there's horrible knee pain. And if a young person hates the way their legs look and they've got knock knees or bow legs, to me, that's a perfect time to correct the deformity because you will change their natural history. For extra-articular deformity, you will improve pain and function with realignment, even in the setting of arthritis. You'll delay or prevent arthroplasty depending on when you do it and how bad the arthritis is, and you will improve aesthetics and body image. It also allows you to correct rotational deformity, which is not something that can be done during a knee replacement, right? You cannot correct rotational deformity during an arthroplasty of the knee. Think about setting the stage for a future arthroplasty, and don't burn bridges for your future arthroplasty. And in terms of correcting leg length discrepancy and deformity, use a hexapod frame if you are interested in correcting length and complex deformity at the same time. But of course, internal fixation techniques can be used for this as well, such as the internal lengthening nail with blocking screws and fixator-assisted techniques. So what I have learned from my experience is that healing is not really just science. It is the intuitive art of wooing nature. This is a quote by a famous American poet. And I really think that this applies to osteotomies about the knee, because what we as surgeons do is we create the optimal biological and mechanical environment for the body to heal itself and for tissue to regenerate. And so it's been my great pleasure to present this lecture to you all. And I appreciate you all listening. And I look forward to seeing you all in person, either in New York or hopefully at a future upcoming visit to Cairo.
Thank you so much. It was impressive, Dr. Rob.
Thank you.
It was really amazing cases, and we are receiving great comments from your friends all over here and all over the world as well. So without disturbing the program, I'm gonna to share my screen for just a quick presentation, and we're gonna to leave the questions till the end if you want. It's okay?
Yes.
Okay, thanks. Do you see my screen? Okay. So I'm going to present a very quick case of mine. She's 15 years old girl with bilateral bow legs. She's the only one in the family, no brothers or sisters. She has normal developmental history. However, she experienced during her childhood a severe rheumatic problems, and she went up by this Valgus deformity. And unfortunately, I don't have a real good preoperative clinical photo except this one, but it's showing the deformity. So apparently, when you look at this X-ray, you can see there is apparent asymmetrical femoral varus, maybe on multiple levels, and also we have tibial varus, maybe on single level. So this is only apparently we should plan how to do. So options of fixation, as we all know, might be either internal fixation, IM or surface plating, or external fixation or a combination. So first of all, we have to think about both planes, frontal and sagittal, because most of these cases have what's called oblique plane deformity, and we have made the scanogram available to make sure the plane is well. And apparently, as you can see, there might be a deformity in the femur here, there, and the tibia here or there, but we should draw our lines. So by drawing the mechanical axis of the femur, we can, and the tibia, we can notice that the LDFA was in the right side 68 degrees and the MBTA was 80 degrees. So primary the varus in the femur and secondary in the tibia. So let us focus about tibia first because I think the symbol. So once we draw the proximal axis and the distal axis according to our rules, and we find the cora, and it was about 11.5 centimeter from the ankle joint. So when we do our osteotomy here, that's type 1 osteotomy level at the cora, and once it should be corrected, should be like this one. So what about the femur? Once we collected the tibia and the mechanical axis is corrected, so we should extend this line and bend on this for the distal femoral mechanical axis and the proximal femoral mechanical axis according to the 3-line method, which we do not have time to express this now. These two lines meet outside the bone. That means there's another deformity, and we should draw another line for the middle segment to find there is a cora here and cora here as well. And these two coras are 14.5 centimeter and 28 centimeter from the knee level using a bone ninja. So now we can use internal or external. I planned for fan techniques, etc., assisted nailing because I believe in this. And we put external fixation just temporarily before doing our osteotomies. And what Dr. Rob had mentioned earlier, it is very essential to think about blocking screws to direct your wire and your reamer, and as well as to protect your correction. So putting two blocking screws, proximal and distal, on the concave side of the deformity, and another one maybe in the sagittal plane in the posteriorly. So let us see, after correcting distal osteotomy and then after correcting the second osteotomy, now the mechanical axis should be aligned well from the hip joint to the ankle, passing in the center of the knee joint, and the mechanical axis LDFA and MBTA is 90. So that's after single osteotomy of the tibia, double osteotomy of the femur, according to our plan. So not only this, we have to think carefully before the surgery what I'm going to use. If we want to know what about our diameter of the nail, our length of the nail, and where is our entry point. It should be a little bit medial, because we know we are coming from Varus to Valgus, so the entry point should be a little bit medially, and we know the place of osteotomy exactly where that, and also the concept of blocking screws. And I think most of you will wonder why I used plating here. I agree with you totally that we could use intramedullary nail for the tibia, but I don't know a specific reason why I used the blade at this point, but I did the nailing for the contralateral side. So don't forget the lateral, the sagittal plane deformity, because most of these have oblique plane deformity. Again, the tibia axis is the coral level is here, again at the same distance from the ankle joint like in the A-beam. Once we correct this tibia, we can focus on the femur. Now the posterior distal femoral angle, as it should be normal, 81 degrees. This is for the distal segment. For the proximal segment, mechanical axis or modified mechanical axis, this one. And again, since these two lines meet outside the bone, so we use the middle segment axis to find out where exactly the second osteotomy or the second cura. So again, don't forget the blocking screws in the AB and lateral direction. Now, once we corrected this deformity by using whatever the technique, or exactly at the cura without any translation, we should achieve this result in, and we should find the posterior distal femoral angle 82, and for the tibia is corrected as well. So this should be a bearing after insertion of the nail retrograde from the femur. Now we planned. Now, what about the achievement of our plan? Because if you know how to plan and you don't know how to achieve this, that's a big problem. So intraoperatively, I can show you just a short insertion wire entry point. As I mentioned, it's a little bit medially in the notch, and it is essential that this wire directed towards where the convexity for the lateral apex in the Varus deformity. So this wire should hit me here. And in the lateral view, again, it is in front of the Blumenstadt line in the notch and directing towards where the convex side of the deformity. So in the sagittal plane directed anteriorly, in the AB plane directed laterally. And following that, we can open the medulla using the 8mm ACL guide reamer, cannulated one, and we can introduce our flexible reamer again in the AB directed to where it should be in the AB, and in the lateral view directed to where it should be in the lateral. Just don't forget, this is our osteotomy level 1 here. And before doing our osteotomy, again, the concept of blocking screws, like Dr. Rob mentioned, we put just one proximal and distal and the concave side of the deformity around the osteotomy level. And this how it should like in the sagittal plane, another one in the posterior segment like this one. So two from in the AB, one in the lateral, maybe another one here, but I didn't do in this case. So this is the wire. This is the osteotomy level. You can see the track of the reamer of the drill bit. And again, since we are using fixator-assisted nailing, I inserted 2 half bends distally, 1 half bend proximally at the level of the distal trochanter, far away from the nail level, which should stop here. And this is the guide wire. And this is the osteotomy drill bit for the distal osteotomy first, and how it should look intraoperative. You can see simulation of the Valgus deformity. This is the 2 bends distally, this is the 2 bends proximally, and on the sagittal plane as well. And as Dr. Rob mentioned, don't forget the rotational deformity. If present, you have to assess it by clinical exam or CT exam and make sure that you are correcting rotational deformity if present. And this is how it appears after cutting the bone distally. Now you can enter and you can pass your guide wire straight in the middle segment. And now the preparation for the second level of the osteotomy proximally to correct whatever residual in the varus in the EB and whatever residual in the sagittal plane as well. And now after cutting the bone and correcting the rest of the varus, you can enter your guide wire all through the femur till the lesser trochanter. And this is how it appears during reaming by using 0.5 increments flexible reamers in AB and lateral, and how it should look after insertion of the nail. And finally, checking the mechanical axis by using a booby cord is essential intraoperatively, whatever the booby cord or whatever method, like Dr. Rob mentioned. So this is the center of the femur, center of the ankle, passing in the middle of the knee. So now the mechanical axis is completely corrected, and you can check this intraoperatively very clear. And this is the patient, how she looks like in the OR before leaving the surgery. And you can find this incision just for blocking screws, this incision is for the locking screws, this for the entry point a little bit medially, as I mentioned, and this for the surface plating. And again, if I'm revising this case again, I might use the same incision to put a nail in the tibia. And that's what we achieved. So that's what we planned for beforehand, and that's what we achieved in the AB view. Looks similar or identical. What about the sagittal plane? That's what we planned for in the sagittal plane, and what we achieved after correction of the deformity in both planes. And this is how it looks like after plating, after correcting the varus and flexion. And you can notice from the fibula break here, I didn't mention that you have to break the fibula, that this deformity is going from flexion to extension, which should be. So finally, checking the mechanical axis immediate post-surgery, we can find that complete correction and the middle axis passing in the middle of the knee joint by using fixator-assisted kneeling in the femur and by using plating or nailing whatever in the tibia. So you should achieve this without the patient have seen the external fixator anymore, just intraoperatively. And that's the X-ray appearing about 6 weeks after surgery, and you can find tremendous callus formation proximally and distally, and it looks like nice, when to heal, and that's the tibia as well. And for just mentioning without details, I use the same technique in the left side, but just nailing in the tibia, nailing the femur as well. And from this view, you can notice that there is no rotational malalignment. This is the lateral, the sagittal plane, this is the AB plane. So I think everything is okay. This is the guide wire entry point for the distal femur. And this is the final before and after by using fixator-assisted nailing in both sides. So this is the patient. Just remember how she looked like before and now how she looked after, and she's now working. Unfortunately, I didn't able to upload the video, but I'm sure she's making well, and she has complete range of motion of the knee without any issues, and now she's living a happy life. So external fixation or internal, that's a big question in the debate. And in the past, we used to use these terrible frames for the patient, especially for the femur. And of course, like Dr. Rob mentioned, it has its indications. However, I should say that whenever you can use internal fixation for correcting deformities, please do it. So remember the different presentations of the deformity. Importance of preoperative planning is very important, and you have to respect your tools of fixation, what you have. And finally, internal versus external, that's what I learned from my professor, Dr. Herzenberg. It is the time for internal shift. So once again, I have to thank Dr. Rob, I have to thank Dr. Austin for listening and for coming, and I hope you enjoyed till now. Thanks. I think now we should move to our friend, our second guest speaker, Dr. Austin. You have the mic to speak about tibial perspective of around knee deformities, please.
Okay, can you guys see my screen?
Yes.
Can
Go
you hear
ahead,
me?
please.
We're good?
Yeah, sure.
Okay. Well, thank you, Ahmed, for inviting me. And that was an excellent case. And I think your pre-op planning was meticulous. And you bring home the point that each case is slightly different, and we need to customize our treatment for each patient. And yes, there's definitely a shift toward internal fixation. I see that Yasser El-Batrawi is here, and he's made some comments and good questions. So we'll look forward to answering those. And we again thank him for helping us to get into CCOT with a nice publication in his specialty journal. And then our connection with Egypt goes deeper. We've trained 4 fellows now from Egypt. We have Amgad Halim and Sam El-Attar and Sharif Dabash and Sharif Galal Hassan, who's just finishing up with us now. And these guys are very well trained, and it's a real pleasure working with them. So yeah, I'd like to pick up on several things that Rob talked about and get into more tibial osteotomy, tibial based. But you can see there's a lot of, it's not a firm border between femur and tibia, and we have to be able to be somewhat fluid and use both femoral and tibial osteotomies for the deformities we're treating. I do have some disclosures. Okay, so let's look at a simple tibial case. And this is a type of genu varum case that is very typical in the US that we treated with an opening wedge osteotomy of the tibia. So we have a patient who's 34 years old, she's a female. She has a mechanical axis deviation medially of 24 millimeters. And the chart that Rob showed, I use the same sort of chart. You can see how much stress there is. It's all in the lateral, it's all in the medial compartment. There's no stress in the lateral compartment whatsoever. And it's even over her body weight. So even a small deviation like 24 millimeters is quite pathologic for the cartilage. And how do you approach this? Well, the majority, you of course look at LDFA, MPTA, majority of deformities coming from the tibia, which is usually the case for Varus. And we can use our planning. Now we use our PAX system, which is kind of like Bone Ninja, to do the planning, and it really facilitates things. We've validated this technique where we can use the Sectra equipment to do pre-op planning. The plan is to do a 9.9 degree opening wedge osteotomy. And, that goes very smoothly. And, this is a very simple case with a partial cut, leaving the lateral hinge intact, and then hinging it open, putting a bone graft in and putting a plate on. And, I'd say there are several sports surgeons in the US who do this type of procedure. And of course, Rob and I do this type of procedure very frequently. So mechanical axis is very easy to control with an opening wedge. As you use the laminar spreader, you can dial in the correction to exactly where you want it. How you measure it intra-op, I typically use the same system as Rob, which is Tomofix has a rigid long metal rod you can use that you put together. And it's kind of like the Bovie cord, but a little more rigid, maybe more accurate, I don't know. But you still have to watch out. This is a simple case, but even so, an opening wedge will increase your leg length. So nothing simple. And she ended up with a leg length discrepancy after the case because it turns out that her right side was a little bit longer than the left. We had a discussion about this preoperatively. I still prefer this over closing wedge. And it's just another thing you have to think about, that even the simple case isn't so simple. What happens when you have a larger deformity though? What happens when you have a large varus deformity? So that's, that was 7 degrees. It's not a big deformity. What happens when your mechanical axis is out here at 60? It's not even on our chart. Our gate lab biomechanics team didn't even predict that type of varus, so they didn't even chart it. So yeah, so the problem with these major varus deformities is you can't just correct it through the tibia, right? And if you actually analyze this, you'll see the tibia is definitely off. It's 81 degrees. We know it should be 87, 88. The femur is also off at 94. So with a larger deformity and I would say over 12 degrees, you need to start thinking about this is probably coming from both bones and probably should be corrected through both bones. And of course, there's medial compartment wear and degenerative meniscus tear still in a young patient. So this is not an arthroplasty patient. So the plan is to correct both femur and tibia. And how do you do that? Well, that's sort of your decision. You can do a medial opening wedge. You can do a lateral closing wedge. If you look at leg lengths, then you can see this side is shorter, but you need to predict how much longer it will be at the end of correction. That helps me decide between a lateral closing wedge and a medial opening wedge. So I do a lateral closing wedge osteotomy here, and then I use an old technique, fixator HTO. So a osteotomy inferior to the tubercle, comes across the bone almost all the way, leaves a lateral hinge intact, and then we can dial out the correction with the fixator. And what's the advantage of that? Well, this patient has some knee laxity. So my ability to correct the tibia gradually and then fine tune it based on the patient's post-op weight-bearing x-ray makes me feel more secure because I will be less likely to overcorrect the tibia. When you have laxity in the knee and someone stands, there tends to be hyper exaggeration of the varus deformity through the LCL laxity. So if we're not going to address the ligament, then we have to be a little bit careful about not overcorrecting the deformity we measure in the mechanical axis. So it's a safety net to be able to use an external fixator. It's a simple monolateral frame, and we can dial in the correction. And then you can use it for a toy for your child afterwards, or reuse it. You know, it depends on what the policy is in your country. And we've looked at this, the accuracy of this device and correction of proximal tibial varus with external fixation, found it to be very accurate. And the ability to dial in is a theoretical advantage, although we rarely do change from the original plan. Okay, here's a patient with an even larger varus deformity. Again, I'm thinking femur and tibia because with this big a deformity, there must be some contribution from both. But look at his laxity of his LCL. He has severe LCL laxity. So another strategy here is to reconstruct the LCL. If we reconstruct the LCL, we eliminate the play in the knee, and then suddenly our measurements are more accurate. So we can sort of eliminate a lot of the joint line deformity and really just focus on the femoral deformity and the tibial deformity. So if I focus on my femoral deformity correction, my tibial deformity correction, and ignore the joint line correction, then here showing mechanical axis under correction will actually give me a slight overcorrection once I fix the LCL. And in this case, I did in combination with a colleague, and you know the nuances are this. With an LCL reconstruction, I can't do a lateral closing wedge osteotomy because then I'm right in the operative field of the LCL reconstruction and I can't put a plate right on top of it. So I was a little bit stuck doing a medial opening wedge osteotomy, which will give him more length. But again, in the end of this, we're going to do both sides a similar fashion, and therefore his lengths will equalize. Similar deformity on both sides. So in this case, what I typically do the femur first. This is the femoral opening wedge osteotomy, the exact number of degrees that I wanted based on my preoperative plan. And then intraoperatively, I will measure and dial in my correction on the tibia to make sure my mechanical axis is straight. And I use a combination of techniques, either the long stiff rod to measure the mechanical axis, or we have a tool now called RadLink, and I'll show you this again later, that allows for stitching of intraoperative fluoro shots, reproduction of mechanical axis, reproduction of LDFA and MPTA. So you can measure your LDFA and MPTA intra-op, which is very cool because if I don't like it, I can just click it open a little more and change my MPTA or a little less. So that's pretty neat. And then in the end, again, slight overcorrection, it's pretty standard for varus. And, you know, we always want to be sure we're not affecting the sagittal plane, right? So we certainly don't want to change the sagittal plane in someone whose knee goes to full extension and has no real sagittal deformity. And we always have to be very careful with HTOs that we don't introduce flexion. So I always get an intraoperative lateral x-ray and again, measure my PPTA using that system. If not, you can at least look at it and try and get a visual sense of whether you change the sagittal plane. And after both corrections, these are the mechanical axes. Okay, so what's another good indication for tibial osteotomy? Well, tibial slope that's excessive after failed ACL reconstruction. So we see this a lot in the US, where we'll have people who fail 1 or 2 ACL reconstructions, and finally it dawns on everyone that, hey, maybe there's a tibial slope problem here. So that's what's causing the tibia to excessively stress the ACL reconstruction. We know the ACL reconstructed ligament's not as strong as the native ligament. So here's an example. This is a young girl, 21 years old. She's still at university. She's failed 2 ACL reconstructions. She's a college athlete. And her slope's not horrible, but it's 74. PPTA 74, normal is 80 to 81. So we felt that this was probably enough because we couldn't come up with any other reason why she kept blowing her ACL reconstructions. And these were autograft reconstructions, bone, patellar bone autograft. So the decision was made to correct the slope. Well, how do you do that? A couple other issues. She has the tunnels, which still have the screws in them. We want to fill those tunnels with bone graft so that she's already had 2 tunnels drilled out. We want to bone graft the tunnels at the same time as the slope correction, and then set her up so that she has a nice, good, filled in proximal tibia to work with for the 3rd ACL reconstruction once the slope is fixed. You can see her knee does not come to full extension. So that also makes me feel better about increasing her extension. And I decided to use a good old hexapod external fixator in order to do an infratubercle osteotomy, stay away from the ACL tunnel, stay away from the bone grafted area, so that we didn't get an infection in the bone graft because it's grafted with allograft, and so that I can correct the slope with great accuracy, because I feel much more confident not introducing varus or valgus deformity when I do a sagittal plane correction in the tibia. I feel much more comfortable using a hexapod. So there's the tibial osteotomy, typical infratubercle osteotomy, multiple drill hole with an osteotome. You can see this pin placement stays away from this medial tunnel here. So I keep the pins a little more lateral, so you can really customize your treatments. Again, why use the TSF? Because it's incredibly accurate. This is actually the max frame, but it's a hexapod frame. They're all incredibly accurate, and they get the job done. And this is what the final slope looks like. Where do you correct the slope to? I think that that's an interesting question. Paley always says, don't go past 90. So, you know, the goal was to do about 10 degrees. And this is a little bit of a hard angle to measure. It may be really more like 84. And I think we achieved that 10-degree correction. She has clinically full extensions. That's another factor that goes into how much do you correct it. So I was very pleased with this. And she goes on to heal all the way. She then went on subsequently to get her ACL reconstruction, and it's been a year. It hasn't had any problems, and she's back in sports. So I think this was what she really needed. So on the theme of correcting genu varum and through the tibia, one thing we find is that genu varum is often associated with external tibial torsion. So everyone thinks about Blount's disease and how genu varum is associated with internal torsion because of the teachings of Blount's, but it's actually associated with external torsion much more commonly, particularly in patients with congenital genu varum who don't have Blount's disease. And in fact, we studied this and found that 50% of patients presenting to our office who had genu varum bilaterally also had external tibial torsion that was excessive beyond 20 degrees of thigh-foot axis. So I thought this was very interesting and something to definitely look out for. How do you correct this? Well, now you have a biplanar deformity. You have varus, you have rotation. And I still believe that the best way to fix that is using the hexapod external fixator to correct both things simultaneously. I have done this with an IM nail. I think that that is a very interesting way of doing this, but you really need to be a sharpshooter with your IM nail. And I feel like you need to do a suprapatellar approach to get a perfect start point to do varus and rotation with an IM nail. It can be done, depends on where the deformity is. The closer to the joint, the less reliable an IM nail is. And then with the hexapod, it's simple. You put your deformity parameters in, you program the frames, you get a perfect correction every time. Neutral mechanical axis. So we also found that the correction of genu varum really gives a profound improvement in patients' gait. So we kind of all know this just clinically, but we went and studied it with some PhDs and found that the adductor moment decreased to an absolutely normal level after doing correction of bilateral genu varum. So, you know, this is further evidence that correcting genu varum prophylactically will neutralize the abnormal forces in your knee joint and prevent arthritis, which is hard to prove. We kind of all know it's true, but this is just another piece of data to add to that collection to show this. One point about varus, and Rob kind of made the point too, is we always think of varus coming from the tibia. And if we look at this analysis, we can see these sides are both pretty similar. The right side's 34 medial, left side's 29 medial, similar deformity. There is a leg length discrepancy, which is mostly coming from the femur. But when you go ahead and look at your joint orientation angles, if you look at the left side, this is sort of the classic genu varum, 81-degree MPTA. So if we put that at 91, this will be symmetrical. That'll be a correction. Good tibia correction, right? What about this side? Well, MPTA is 87. I mean, that's a normal number. What's the LDFA? 97. So this is way over normal. So you really do need to pay attention. And I actually repeated the long film on this patient just to be sure that my eyes weren't deceiving me before putting him through surgery. But in this case, my goal would be to correct the tibia on the left side, correct the femur on the right side, because this was still true with a repeat x-ray. And in this case, I decided to use an external fixator. No reason you have to do this. You could easily do an opening wedge, acute correction, tibial osteotomy with a plate. Absolutely dealer's choice here. And for this side, this is a similar case well, much simpler than what Ahmed presented, similar to what Rob was presenting for distal femoral osteotomy. And we have the luxury of using the magnetic internal lengthening nail in the United States. So I went ahead and used that. And same idea we've all been talking about, the use of blocking screws for retrograde nail correction is critical. The posterior blocking screw is very important for lengthening nails or for LON. Very important. So it helps get the correction and maintain the correction. Now in trauma, a lot of the traumatologists will use blocking screws just temporarily. In fact, put drill bits in or Steinman pins, get the correction, lock it, they're done. They pull the blocking screws out. But in lengthening, you need to keep them in because as you lengthen, you'll get lengthening induced deformity, which is what we want to avoid. It also helps get the correction, so why take them out? And here's the correction. Gradual lengthening and correction of mechanical axis through the distal femur. So now we have equal leg lengths and we have equal mechanical axes. I did not overcorrect the right side because he has no arthritis on the right. I did overcorrect the left because he has medial compartment narrowing on the left. And this technique we wrote up with colleague Chris Jobst, who's a pediatric orthopedic surgeon and part of the LLRS. And this is a scientific article looking at the retrograde nailing, fixator-assisted retrograde nailing, and has some sort of fun findings that we were able to determine after statistical analysis. So it's worth a read. So what's the role for tibial osteotomy in valgus? So I've only really presented varus cases. What about valgus? Well, as Rob showed, valgus is typically a femoral problem, and you can do a distal femoral osteotomy to correct your valgus. What happens when the valgus is more than usual? So here's a patient with genu valgum bilaterally, right? The right side, though, is fairly high, 36 millimeters. I mean, this is a lot of stress on the lateral compartment. It's definitely more than the usual. It obviously looks horrible when you're looking at the patient when you have that much lateral mechanical axis deviation. And here we are. Interesting. So we have 86-degree LDFA. Technically, that's fine. We have a 94-degree MPTA. That's not okay. So clearly, there's a tibial problem here. Patient does have patellar issues. You can see the patella is subluxed. So we're going to fix the patella. we're going to do an MPFL reconstruction, but I really need to do some correction of valgus through the femur in order to get that patella to shift, as Rob was talking about. So even though this is a normal LDFA, I'm inclined to break the femur to help my patellar tracking. But I can't do all of it through the femur because then I'll have 94, 94. I don't really like that. A lot of times the valgus knees, you'll see there's an obvious valgus diaphyseal deformity. So you can take advantage of that. You can straighten the diaphyseal deformity in the tibia, get a perfectly normal tibia, and then do a dial-in correction to get your mechanical axis straight through your femur. So the tibia, you kind of do an acute correction, you do whatever you get, right? You do your planning. It's usually very accurate, but sometimes it's hard to know exactly what you're going to get with a tibial nail, right? What if your start point's a little off? It will change your planning. So this is exactly what Ahmed was talking about intra-op execution of your planning. So tibia, harder to control with a nail, but I get an acute corrections in my planning, and my planning is a 7-degree opening wedge. So I've reduced that, 13, 14-degree valgus to 7-degree opening wedge to the femur is a much quicker healing time. And I'm using allograft, so it incorporates faster. This was the final product, exactly what we wanted. The screws are short, so the MPFL reconstruction tunnel is not messed with during the correction. Another thing worth talking about, and this could come up in discussion, is Nsaid use. So we use Nsaids very rigorously on every single osteotomy patient. Everyone gets Toradol right after surgery for 24 hours, and they all go on to Motrin 600 or meloxicam 15 milligrams. And we have not seen any issues with osteotomy healing. For every single case I just showed you, every one of those patients was on not high dose, but normal dose Nsaids, typically for about a month, just so you keep that in mind. What about intra-articular deformity correction? So this is an interesting topic, right? This case is actually going to be very similar to Ahmed's case. I think it's really neat. Slightly different approach, but not a lot different. Same sort of thing, nutritional rickets from sub-Saharan Africa. And the patient, young girl, right? And you see this horrible deformity. And of course, there's instability too. The instability is a lot worse on the left. You can kind of see it gapping open here. So there's sort of a Blount's component to her left side, but not so much her right side. And on this side, you can see that, there is sort of this diaphyseal deformity. The tibia is just weird, the shape of the tibia. So there's diaphyseal deformity, there's a big rotational component. So I did get CT version. You can see that these numbers are way off. So my decision was to eliminate the diaphyseal deformities and the rotational deformities, and then I could get to the periarticular deformity. So a little simpler way to approach this than what Ahmed did. I think that your approach was fantastic. Personally, if I'm doing a 20 or 30-degree rotational correction, I don't feel confident in any of my planning because that will greatly affect the mechanical axis. So once I'm doing a big rotational corrections, and this was like 30-degree rotational corrections, then I kind of don't want to do the periarticular correction. So I just did simple diaphyseal osteotomies, eliminated the rotational deformities, got the diaphyseal deformities eliminated, and then saw what the true underlying deformities were. And in this case, we have laxity and a Blount's type varus, as well as distal femoral varus. And in this case, it's really just distal femoral varus. So we can see we still have 17 degrees of varus on the left side. And what's interesting about this, most of it's from the femur. But look at this. Here's the laxity we have in the knee. So there's a lot of knee laxity. There's a depressed medial plateau. And this I thought was a good indication for distal femoral osteotomy, just to get this back in the normal region, and a hemiplateau elevation on the right, on the medial side. And this is kind of what the planning looks like for that. Closing wedge distal femoral osteotomy is what I planned, and then an opening wedge down here. I ended up doing an opening wedge medial distal femoral osteotomy. It is easier. It's an easier case than a closing wedge. And you can see how much the mechanical axis varies intra-op based on whether I stress it into varus or valgus. So, it's all over the map. So my plan is to push this into a valgus stress, which neutralizes my mechanical axis, and say, that's how much I'm raising my plateau. I'm going to raise up my hemiplateau, so now I'll have no more laxity in the knee and put it in a normal range. And that's what we did. Medial approach, osteotomy up toward the center. These wires help prevent cracking into the joint. And then you lever the joint up and you get it level. It's an intraoperative move. And then I use a plateau plate, like a lateral plateau plate on the medial side, and just straighten it out a lot. I've done a bunch of these. These are great cases. Eliminates all the laxity in the knee and finalizes the deformity correction. So that side's perfect. And then she still has a little bit of varus on this side. Again, we'll do a Preoperative correction, which is a closing wedge femoral osteotomy. And I just did this last week. And again, this is the Rad Link device. We're spoiled. We have all sorts of great equipment, but this thing's really neat because you can take your images and measure exactly how many degrees you have to make sure your wires are at the right angle, make sure your wedge is the right size, and then check your intraoperative alignment. So we did a lateral femoral closing wedge osteotomy to equalize leg lengths and finalize the alignment. And then I actually ran into this patient when I was in Washington trying to convince Congress to feel badly for orthopedic surgeons. And it's always good to have a patient on the inside showing how well we affect people's lives and how important our work is. So what are some of the future directions? Well, I find that these intra-articular hemiplateau elevations are tricky, and they're probably best done with the help of some of these custom cutting guides. So that the next one I did, I used New Clip, which is a French company, and custom cutting guides, and it just made the whole thing a lot easier. Here's the final result with the allograft wedge. I just cut a femoral head and made it, fit in nicely. And this is the hemiplateau elevation. Hemiplateau elevation, I still find you need to fix a metaphyseal deformity even after doing the hemiplateaus much of the time. So she's just finished her correction with a hexapod. So I did the correction here, let it heal, came back 6 months later, took the plate out, and did an infratubercle osteotomy to correct her PPTA the rest of the way and to fine-tune her mechanical axis. Future directions of hexapod. The orthospin struts are amazing. This is an Israeli company. And here's a patient who has a biplanar deformity of varus and flexion. And we use the system. It was really amazing. Here's our dream team at HSS. This is our new partner, Taylor, and then Rob and I. And we all were involved in this mating case. So we did one side with orthospin, automatic adjusting struts, computer driven. So really neat stuff. These adjust themselves. You can do any number of adjustments per day, but you could program it so all 6 struts adjust 10 times a day. So if you're moving 1 millimeter, you're doing 1/10 of a millimeter 10 times a day. Some struts obviously don't move when you're doing angular corrections. Others move a lot. It can sense how much energy is going to each strut, and then you can slow it down, slow that strut adjustment down, and break it down to 50 times a day. This patient reported much less pain on the orthospin strut side than on the standard strut side. And I think there's a lot of potential here. I've used this on a few patients now and will continue to do so. They really like not having to adjust the struts. This final result is excellent, so I have every faith in the system. I encourage all of you to submit articles to these 2 journals. I'm sure you're all very well aware of these journals, JLLR for Milind Chaudhry out of India, and then STLR, which is the British Limb Lengthening Society's journal. They're both official journals of LLRS. I have my LLRS shirt on. I'm still the president, and I'm going to do 2 terms. So that's interesting. And a shout out to LLRS. And, we're holding this thing at night in 2 weeks. And I said, what is Europe and Asia and Africa going to do? None of them can tune in, but I was overruled by the rest of the board. So we're doing it at night. But you guys can tune in the next day. It's all going to be recorded. We have a virtual meeting with pre-recorded talks. There's at least 40 pre-recorded talks. And then the live session's 2 hours, which is going to be hard to watch live when it's at 8 p.m. Eastern Standard Time. But you can watch the next day for sure. So we'd love for you guys to check in with us and and watch our event. And thanks again to Ahmed for putting this together. I look forward to answering any questions.
Thank you so much, Austin, and forgive me for the past president. You are the past and the least.
Past and current.
Yeah, exactly. So during your presentation, I see Dr. Rob did a good job in answering some of the questions. Thank you. And I'm just wanted to point a few of them for all of the audience, if you don't mind. So if you can open your mic, it is off, Dr. Rob. All right. So thank you again. There is a question from Dr. Muhammad Abdulal. Combined fixation plate and nail increase the risk of a stress fracture at the fixation screws. Do you agree?
Yeah, so whenever there's the nail ends and the plate starts, there's always a potential area of stress. But I have not seen any problems. We're gonna actually, we have a number of these cases now. We're gonna write it up to publish our experience on that. But I haven't seen any fractures in between. And I routinely take out my plates and screws a year later. So it's not going to be a long-term problem. And most of the patients that I'm doing this for are young people. So the bone quality is pretty good. So I would say, it just hasn't been a problem. It's a theoretical problem, but it hasn't really been a practical problem.
Great. And I think we have few cases so they can forward it to you for the publication as well.
But one point that I would make is use lateral to medial screws. Don't use anterior to posterior screws. If you're going, when you have a nail that ends in the middle of the femur, and you do anterior to posterior screws, that probably is more of a risk for a fracture.
Okay, I see. So in the frontal benin, not in the sagittal benin, you mean, right?
Yes. Yeah.
Okay.
Better to put the screws in from lateral to medial.
Okay.
I think part of the issue is our patients are young, so they have really strong diaphyseal bone. I think if the fear comes from patients who have joint replacements who are 70, 80 years old, and I think it's a big deal there. But we're not doing these combo double level femoral osteotomies on 80-year-olds. So I think that's why we get away with it. It's because we have good, young, strong bone, and it's not an issue.
Okay, great. Professor Amra Azam is asking lateral translation of distal femur during distal femoral valgus correction by lateral opening wedge technique. Does it decrease the amount of open wedge osteotomy? You got the point? If you're doing a distal femoral opening wedge osteotomy, with some bilateral translation of the distal femur, so this translation should decrease the amount of osteotomy you need, opening wedge you need?
Sure. So so absolutely. Translation, both translation and angular change affect the overall mechanical axis. And so you have to take that into account with your planning. But with the opening wedge technique, you're trying to avoid translation. So there really shouldn't be translation with an opening wedge technique. Okay. And it's not really an opening wedge technique.
It's just translation.
What we've seen, we have an old publication where we looked at plating versus X-fix using monolateral external fixator rails. And if you really look at where the osteotomy is, it's completely changed. The osteotomy for a rail is much more proximal in the distal femur, right? Because you have to fit 3 pins. The first pin starts, the level at the top of the patella. So your osteotomy is high. It's way far away from the cora, and you have to translate, right? If you look at these osteotomies that Rob showed, they're very low. And he even angles it lower. So it's barely just grazing the top of the femoral condyle posteriorly, right? So you're really close to the cora. So you really don't get much translation. Same with HTOs. The closer you are to the joint, the less translation you get. You're very close to the cora.
Yeah.
Okay, great. So there is a question coming from Dr. Tarek from Germany. Thank you very much for this. I wanted to ask, do you have any experience with using an orthopilot, which is computer navigation, while performing osteotomy? And do you feel this makes better or not?
You know, I want to answer that because this has been a source of frustration for me for many years. You know, you may ask, why are we still using a stupid bovie cord or like a stick? And for some reason, a navigation system for osteotomy does not exist in the United States, believe it or not. It's, you know, there are even a few companies that make navigation systems for total hips and total knees and osteotomy. And the only ones that are available in the United States are the arthroplasty ones. So it's actually been, it's been frustrating for me. I would love to be using a navigation system and really try to really hone in the accuracy of these. But I haven't been able to, we haven't really been able to find. I think the system that Austin showed, the OrthoLink, is the closest thing that we have to a navigation system available in the United States for osteotomy and realignment.
I see. All right.
But yes, I would like to use it. Maybe that's a shout out to the.
Are you ready? Yeah.
To the companies. We'd love to try that. It's not. It shouldn't be too complicated.
I think from US to Germany, not a long trip. You can go there.
Yeah.
Okay.
Yeah.
Good. So there are few. There are actually a lot of messages will come in, both of you from Nigeria, from Russia, Dr. Victor, from Dr. Olanion Sunday, so from many countries, from India as well. Okay, how would you correct lateral laxity? How you deal with the lateral joint laxity?
Austin, you want to take that? Because I think.
Sure. Yeah, so I mean, this is a common problem with Varus, right? So we actually just had a conference with the top sports surgeons in the world on this topic. And the consensus was the vast majority of times you do not need to correct laxity through a ligament reconstruction. Usually you just correct the mechanical axis and the laxity is no longer a problem. And I think that that's true. And that would be my number one answer. But as you saw, I showed a case where this was an athlete with a big varus deformity who really tore his LCL, and it was incredibly lax. And I thought that even a correction wouldn't really get him to the point where he could play cricket again, which was his game. So that an LCL reconstruction really was a good idea in him. Okay,
good. So in case of long-standing Blount disease, and there is a joint laxity as well, do you use the method of getting the fibula down with your osteotomy, making your osteotomy proximal to the tibial tuberosity, and then bringing the fibula down while you are doing correction?
I'll take this one.
Yeah.
Yeah, so I think it's a great question and a really neat trick.
That's
and
mine.
Yes, I do. So here's the thing. It depends where the fibula is, and it does vary. So if the fibula is malpositioned and too proximal, then I say absolutely pin it at the ankle, do your tibial osteotomy, and do not cut the fibula and pull it down into position. That'll tighten your LCL. It will give you a little flexion, but you have to make sure that you have room for that. But yeah, it's a great technique. If the fibula is at the normal level, and sometimes it is, and you still have laxity on the lateral side, then I usually do not do that, and I just leave it alone. I'm not going to pull a normally positioned fibula into an abnormally positioned fibula. So it does.
So what you do for this case? Do you make a soft tissue reconstruction for the lateral laxity, or? I
do a hemi-plateau elevation and raise up the medial side, and there's no more laxity.
Okay.
It's actually not laxity LCL in a lot of those cases. There's a pothole on the medial side, and it just falls into it. You raise up the medial side, and suddenly, there is no laxity of the ligament.
All right.
Austin, have you ever done an acute shortening of the fibula with a plate, acute shortening, and then pull it down with a plate?
I have not, but that's a great idea because sometimes you don't want to lengthen the tibia, which is required to pull the fibula down without shortening.
Right. Yeah. I mean, I think that's an option. Fibula lengthenings and shortenings, it's funny. I just did a fibula shortening at an ankle just a couple of days ago, and it was quite dramatic how effective it was in correcting the ankle. And I think that becomes another option. I mean, when we're not using, with fixators, it's a whole different story. You're cutting it, you're pulling it down. But if we're doing something with internal fixation, the idea of cutting out a small segment of the fibula and then using an articulating tensioning device to pull it down might actually be a good option. I have not done that. I just kind of thought about sort of bringing it up, and I think it's something that we can potentially explore. If you pull the fibula down 5 millimeters, it's going to tension things.
Great. I'm gonna to try this one in suitable cases and see the results, how it looks like.
Yeah.
Great. All right. So what about the range of knee motion after acute deformity correction by retrograde nail femur? I think the question focused more for the retrograde nail femur. Do you feel any problem?
Yeah, I'll take that. I think, I have not. It's unusual for a patient to have knee stiffness after a retrograde nailing. I think part of it is, I have had one patient who had a stiff knee, but I would say 95% of my patients have gotten their knee motion nicely. Clearly, you have to make sure that the nail is not sticking out into the knee. We do a very minimal incision technique, where we really make an incision that is percutaneous, and the incision is only maybe 1.5 to 2 centimeters. And I think that without making a big incision and making sure that you flex the knee appropriately while you're doing this, you can avoid trauma to the knee, and it doesn't require that they get their knee motion back very, very nicely.
Wonderful.
In our study on retrograde femoral nails, right, which I quoted, there was 0 incidence of knee stiffness.
Yeah,
that's my recollection. It wasn't an issue. I'm trying to remember one of the authors, but what we did see was there was one case where the knee flexed as it lengthened because they didn't use a blocking screw, and that's a problem. And you may call it knee stiffness when it's actually lack of extension from the knee going into flexion, and that can be an acute problem too. You put the nail in flexed, then that's what I would watch out for.
That's not a real flexion problem. That's from the flexion of deformity of the osteotomy, right?
yes.
Okay. So another question: do you ever use bone graft for opening wedge osteotomy, or how much degrees you can open and not inserting any type of bone graft?
Yeah, I'll answer that. I think that it doesn't make sense to not put bone graft in an opening wedge osteotomy. You should put bone graft. You're trying to get the body to create, bone when it doesn't, in a big gap. Now, having said that, I will tell you, for a distal femoral osteotomy or the proximal tibial osteotomy, you really do not need to routinely put in autograft. However, allograft, do you have allograft available in Egypt?
No.
Oh, that's a problem.
That's right.
Yeah, we have a lot of allograft here. And so it's very simple, honestly. It's freeze-dried allograft. And, I make the analogy, freeze-dried allograft is like a ladder that a vine can grow up, right? If you have a ladder, a lattice, and you have an ivy, you have a vine, it will grow up because it has something to grab onto. There's a lot of healing potential, but it just needs a scaffold. Do you have coral available?
No.
No? Coral's another option. Or, some of the injectable things like calcium.
We have injectable.
Yeah. So a calcium sulfate, there's a product that I really like. So what I do is I put in a piece of freeze-dried allograft that maintains the correction, and that kind of fills in maybe 25, 30% of the space. And then I inject my favorite product these days is called Cerament, and it's a combination of calcium sulfate with hydroxyapatite. And you can just inject it in to fill the space. it creates some stability, and then little by little, with creeping substitution, you get bone growth, and it works really, really nicely. But I wouldn't leave it open. I would put something in there. So
whatever the degree is, like even
yeah,
like 10 degrees correction.
yeah, anything. You might as well fill it. Why leave it open? Then
Okay.
the bone has to jump over the cliff, over the gap.
Mm-hmm.
It's going to heal faster with something in there.
Mm-hmm. Okay. Do you think there's a big difference between calcium phosphate and sulfate while doing filling of the gap?
Austin, you want to take that?
Yes.
Thanks.
I just want to share the
Do I
spotlight.
think there's a difference between the plate and the gap?
No, calcium phosphate and sulfate.
Oh yeah, calcium sulfate. Listen, calcium sulfate is awesome for delivering antibiotics, but as a graft, it's horrible. It disappears in 6 weeks. It's gone. So it's not a good graft material. See, what Rob's using is more than 50% hydroxyapatite with calcium sulfate mixed in. So it just becomes more porous when the sulfate's gone after 6 weeks. But you need something to stick behind that.
Mm-hmm.
So yeah, there's a big difference between the two.
Okay, good. For the metabolic bone disease patients like osteogenesis imperfecta and other diseases, do you have any tips and tricks while using these techniques for fixator-assisted plating or nailing mainly for correcting huge deformities in these patients away from normal other patients? Do you think there's a difference between metabolic problems or other normal problems?
I mean, the metabolic problems, the bone may take longer to heal, and you do see more incidents of multi-apical deformities, kind of like the case that you presented. So I think the point of being prepared to do double level osteotomy, fixator assisted, is very helpful. I think it's very helpful.
Good. Okay, there's a question coming from India. Do you make any adjustments for lateral laxity preoperative planning based on joint line conversion angle or based on what for the joint laxity?
Yeah, I mean, that's a good question. And, your intraoperative, so that's what we call the seesaw effect. And if somebody gave me a lecture and said, the advantages and disadvantages of external and internal fixation, clearly the advantages of external fixation is that you can get the patient to stand and you can see how the seesaw effect of the laxity in the joint plays itself out. Having said that, I think that you can use your alignment tests in the operating room by simulating weight bearing, neutral weight bearing, as opposed to like pushing it all the way into valgus or all the way into varus. I think is a reasonable way to go. Okay, but I will say that when you've got a lot of, when you've got complete loss of joint space on one compartment of the knee, like complete loss, it becomes more difficult. And if it's an older patient, that's when you should start thinking about arthroplasty.
Good. Right. There's a question from Dr. Yasser al-Batrawi. How to prevent extension of the opening wedge osteotomy, distal femur to the far cortex? How to avoid breaking the far cortex?
Yeah, you have to make sure. Hi, Yasser. Shout out to you. You have to make sure not to aim it to the diaphyseal bone, and you really want to aim it more distally into that metaphyseal bone. It's a key. It's really, really a significant. When we first started doing this, I did it that way, and I had some cracks, and then I kind of did it this way, and then Austin still was doing it this way, and I kind of showed him, like case after case, how that eliminated the problem. Then he started doing it down into the metaphysis, and it eliminates the problem. So 2 things. I mean, you want to make sure that you don't do your bone cut within about 15 millimeters of the other side, right? So be careful. And And I think that's the finesse part of the case. That's where you put your osteotomes in, you make sure you don't dive in too far, and you work it. You have to, that's the finesse part of the case, is to work it, be a little patient, do multiple passes of the osteotome, understand the length that you need, and don't overdo it. So I usually will, measure the length of my osteotomy. I'll usually put an osteotome in, and I'll look at it with fluoro, and I'll determine, okay, 50 millimeters is the depth that will avoid creating a problem of cracking the cortex. And then without fluoro, I will just keep passing the medial, that 50 millimeters, and I'll go in the back and I'll go in the front, and you just take your time. You do about, I'll usually do, 5, 6, 7 passes of the osteotome till I mobilize it optimally. And then you put your laminar spreader in and you do it slowly. That extra few minutes during that part of the case is key.
Great. I think we have done most of them. Just a few more. Comparison between biplanar osteotomy and inferior to tibial tuberosity. Comparison between biplanar osteotomy and inferior to tibial tuberosity osteotomy. This is coming from India. If you wanted to make osteotomy inferior to tibial tuberosity or biplanar osteotomy.
Oh. I see what you mean. You mean for an acute correction.
We do a lot of biplanar osteotomy. In fact, I almost always do a biplanar when I do an acute correction using the plate, right? We use a Tomofix plate. We'll do the angled cut, and you have to cut a biplanar cut to get behind the tubercle. I mean, that's pretty standard for Rob and I. How do we decide which to do? I think that the answer is that if you have a less than 10 to 12 degree correction that you're doing through the proximal tibia, then you can easily do a biplanar cut and use a plate on it. If it's a larger deformity or a multiplanar deformity where there's flexion that you want to fix particularly, right? If you do a big opening wedge biplanar acute correction cut above the tubercle, you will get slightly more flexion. So if you actually want to decrease the flexion, it's a bad surgery for that. If you want to fix a flexion deformity, I will definitely do that below the tubercle and use an external fixator. So that's the way that I do it. So multiplanar deformities, rotation, sagittal deformity, you want to add any length. I think those are all really good ones to do below the tubercle. Otherwise, if it's just simple varus, you can do it above the tubercle and do a biplanar cut.
But I think for the standard sort of HTO where we do an opening wedge, it's better not to make the osteotomy below. I think that may be the question, like making it below the tubercle. I would advise against, because it's the same sort of thing. You're aiming right towards the part where it's going to crack. It wants to crack. And you're much better off aiming it obliquely and going into, like, you aim to about 1.5 centimeters from the joint on the lateral side. And that mandates that you do an anterior. You have to make a biplanar cut so you don't plow right through the tubercle. And it may seem complicated the first time you do it, but it's actually very straightforward. You just have to protect the patella tendon, and it works very, very nicely to make the biplanar cut. It's, I think that was popularized by the Germans, by Leibenhofer, and it's a very nice technique.
All right.
Also, the degree of deformity is a big deal. If you have a 18-degree varus and you're going to do an 18-degree opening wedge biplanar cut, then you're going to pull your patella down. You're going to create lots of problems. You're going to over-tighten your medial compartment. You're going to crush your medial compartment. So big deformities, we also do below the tubercle and usually use a frame.
Right.
All right. Dr. Yasser again is typing. He knows that you're going to answer this, and he's happy by this answer because he wants everyone to listen to your answer. Good. So last question, I guess, coming from Alexandria, from Professor Khalid Al-Adwar. when measuring your MPTA, how can you separate your bony-related deformity and that from LCL laxity? How can you differentiate between this bony or soft tissue when you make a planning?
Well, you measure your MPTA from the bone, from the proximal tibia, and then you measure your LDFA also from the bone. And then you measure a separate measurement between the distal femur and the proximal tibia, and you measure your what's called the joint line obliquity angle. And so you really should have three different measurements. And then you have to decide how much you're going to correct through the bone in order to hopefully correct the joint line obliquity. And then, as we discussed, there are certain situations where you're going to do something for the joint line. But yeah, you just have to, you should measure on every case. We'll have a bone, the LDFA, the MPTA, and the joint line obliquity angle, three separate measurements.
Good. And when you're correcting varus or when you're making upper tibial osteotomy for joint arthritis, medial joint arthritis, do you aim to overcorrect to the lateral, to the tibial cortex, or in the middle of the knee?
For arthritis, medial compartment arthritis,
Yeah.
We always overcorrect it. You know, it's an interesting question though, because if the patient is being sent to me for a knee replacement and they have, too much deformity to correct through a knee replacement, that happens sometimes. And I actually won't overcorrect the knee. I will just make the MPTA 90 so that I can get as much relief out of it as possible, but I won't be making the knee replacement more difficult. So except for that circumstance, we're typically overcorrecting, and typically to the lateral spine. So I know this is like probably a whole other discussion. How much do you overcorrect the mechanical axis for tibial varus? I mean, it has to do with the degree of varus, but in the US, if someone has like a stage 3 medial compartment arthritis, they're typically getting like a unicompartmental knee replacement, or maybe even it's actually worse than that and they're getting a total knee replacement. So I don't like doing osteotomies for people who have bone-on-bone medial compartment arthritis, except in different circumstances where they can't get some sort of replacement option. Good.
And lastly, how to avoid the posterior sloping problem of the proximal tibia while doing osteotomy? How do you look to the posterior slope of the tibia and how to avoid change this slope?
We have two laminar spreaders on the medial side. I'll open the posterior one more. So I'll open the anterior one, what I want my correction to be based on my preoperative planning, and then I'll give the posterior one more opening, and then I'll get a lateral fluoro shot and measure the PPTA and make sure that I didn't flex the bone.
Right. So to conclude, I think we, on time, we finished our fantastic webinar with our two guest speakers, eminent speakers, my friend and my professor. Thank you so much for being with us. And I think Professor Ismail Yassin, the head of the orthopedic department, and Professor Hussein, the dean of the faculty, are here just to take the final comments before you leave us. Please, Dr. Ismail.
On behalf of Orthopedic Surgery Department, Al-Azhar University, I deeply thank Professor Robert and Professor Austin, from HS Hospital in the USA for accepting our invitation to share us this great experience. It was really fantastic talks and a lot of information that I am sure that everyone has gained. I am happy to announce that the attending is outstanding and it was great, successful. Thanks for Dr. Ahmed Hamouda, who organized this event. Thanks for Dr. Hussein Abul Ghair, Dean of Faculty of Medicine, Al-Azhar University, for being with us tonight. And thank you for Elixir Pharma, who is sponsoring. Thanks for all our professors and the colleagues who joined us tonight. And thank you for everyone attended. Hoping that our guest speaker would be able to share us other webinars and hoping to see them again on the screen. Thank you for everyone.
Thanks. Professor,
Thank you, Professor
would you like to
Ismail.
conclude?
Thank you, our guest speaker. I would like to thank everyone sharing in this webinar. I am really impressed with this activity, and I would like to thank Professor or my colleagues Ahmed Hamouda for his interesting case. It was really impressive case, and I repeat what you said. This is with meticulous pre-operative planning. It's very important. We are looking forward for more contribution. As Professor Ismail said, please consider this webinar as an invitation to visit Egypt and especially our university, Al-Azhar in Cairo. Thank you for everybody. Thank you.
Dr. Austin, would you like to give a final comment?
Yes, I want to thank Dr. Hamouda and the panel for being kind enough to stay up from 10 o'clock to midnight and entertain us and to organize this great event, which obviously reached international ears. And we greatly value our relationship with our Egyptian brothers. And we look forward to more collaboration. Thanks.
Sure. Dr. Rob?
Yes, I mean, everything has been said, and I must say again, it's deeply our pleasure to participate in this. It's great academic collaboration, and it's a wonderful event. I truly do look forward to visiting Egypt in person. Hopefully, we'll be able to do that soon. And meet many of you in person. And again, thank you for inviting us. It was our pleasure to have this webinar with you.
Thank you. Thank you.
Sure, you will be more than welcome to visit Cairo and every part in Egypt. And not to say more, this is just the beginning. And I hope you can share us with more webinars in the coming few weeks, if you don't mind. Please stay safe. Please say hi to everyone there. Please say hi to your wives. Please just keep in touch. Thank you so much for being here.
Have a good night. Sleep well.
Thank you. Thanks for Elixir Pharma for organizing this, and hoping to see you again on the board. Take care.
Bye.
Thanks.
Bye.